Acute coronary syndrome consists of chronic stable angina, unstable angina, and myocardial infarction. The basic principle is atherosclerosis of the vessel. It can form vulnerable plaque or non-vulnerable plaque. In vulnerable plaque, there is fibrosis and a fibrosis plaque. In non-vulnerable plaque, the oxidized LDL is calcified. Chronic stable angina, the basic pathophysiology is there is dilatation of the vessels due to atherosclerosis. During stress, the already dilated vessels cannot dilate, so there is less blood supply to the muscle, which causes pain. So in chronic stable angina, there is exercise pain, which is relieved on rest. The workup includes stress test, which include treadmill test. The heart rate, it's bring up to 85% of the physiological maximum heart rate, that is 200 plus heart rate into 85%. The ECG shows ST depression. If in case of DVT or obesity or varicose veins, then stress echocardiography is done. In stress echocardiography, IV dobutamine is given and ECG and echo is done. Myocardial perfusion tests such as thallium scan, sestamine scan can also be done. Treatment includes morphine, oxygen, aspirin 75 mg, clopidogrel 75 mg, and nitroglycerin sublingual, and the tablet isosorbide mononitrate or dinitrate for long-term therapy. Injection endoxiparin subcutaneous can be given. In unstable angina, it is due to the vulnerable plaque, that is the fibrous plaque attracts platelets and causes aggregation. This aggregation causes thrombus formation and causes pain. So rest pain is seen in unstable angina. Workup includes ECG, echocardiography. Treatment includes injection abiximab, injection endoxiparin subcutaneous, oxygen, morphine, aspirin, and clopidogrel 75 mg, nitroglycerin sublingual, and beta blockers to reduce the workload of the heart. Coming to myocardial infarction, it is due to the ischemia of the muscle, which later causes necrosis and infarction. The ECG changes seen in myocardial infarction are hyperacute T waves, which indicates myocardial ischemia, ST changes, which includes ST depression or ST elevation, which indicates myocardial infarction, and deep Q waves, which is a permanent change and is a sign of old MI, and loss of progression of the R waves. The cardiac biomarkers seen in myocardial infarction are CPK-MB type, troponin T, troponin I, and lactic acid, which is the last to raise. The first cardiac biomarker to raise in myocardial infarction are heart fatty acid binding protein. The treatment of myocardial infarction includes morphine to decrease pain, oxygen therapy, aspirin and clopidogrel 300 mg oral, injection endoxiparin subcutaneous, beta blockers to reduce the workload of the heart, and in case of pulmonary edema, furosemide can be given, and percutaneous coronary intervention should be done within 90 minutes. If it is not possible, thrombolysis have to be initiated within 30 minutes. Thrombolysis is done by retaptase or streptokinase. Streptokinase, there is a dangerous of anaphylaxis, so adrenaline should be administered in the case of anaphylaxis.